Catherine. Okay. And thank you so much for that introduction. And I want to start by thanking Mo Farhood for proposing this opportunity to me. I'm really excited to be speaking with everyone today on some of our recent work. And I want to thank Catherine and her colleagues for helping me to put this together and put together what we hope will be an entertaining, 30, 40 minutes of science to kick things off here. So as you can see from the title of my talk, I'm talking about imaging with fluorescent compounds. So I know in a webinar, the audience can be have a very diverse background. So what I want to do is spend a couple of minutes of setting the stage for why we want to use these and what our rationale is. Okay. So my research, particularly in this project, is focused in the area of intraoperative imaging in cancer. And as we all know, tumors can form in basically any type of organ or location in the body. And what happens is, even though surgery is the only curative method for removing these types of, removing these lesions, the organ, the home organ, kind of the site of the disease is going to be critical because you want to make sure that you're able to resect tumor without altering too much of the normal tissue. And the way that we do this right now is through it's crude methods for the surgeons. They get in, they use their hands, they use their eyes, they feel around, and then they cut to the best of what they can do. Now, what they do have at their disposal are preoperative imaging techniques, such as standard diagnostic imaging techniques like CT or MRI, or in this case, like a fusion of PET CT. And these modalities can be used before surgery to help come up with a surgical plan, identify the location and maybe the extent of the disease. And then post-operatively, they can also be used to assess the treatment outcome. But what's missing is this gap in the middle right here. When they're in the OR and they're trying to find these tumors and identify where these margins might be or small lesions, that's where guidance is currently lacking other than current visual and palpative techniques. So this really led to the interest in developing the field, the specialty known as fluorescence-guided surgery, or FGS. And as the term describes here, you can use this type of technique to provide tumor visualization in the OR. So this is a direct readout that surgeons can get while operating on a patient. And the opportunities and the capabilities here are you can get a better detection of these hard to find lesions, or you can identify surgical margins. And if these are done, more effectively, what will happen is, complete resection rates will increase and the need for additional surgeries will go down. So this is an example of a robot, a Da Vinci surgical robot used for minimally invasive surgery, and it's got the Firefly detection system built into it, which allows these near real-time intraoperative images to be used by surgeons for determining where and how much to cut. So for those of you that are familiar with the FGS field, you'll recognize this paper quite well. I'm sure we've all referenced it in our grants and our papers. And this was really a landmark moment back in 2011. And this was led by Go Van Dam and colleagues, where they developed the first, they showed the first, I guess you would say, clinical validation of a tumor-targeted fluorescent agent in patients. And up to that point, non-targeted dyes had been used, and they're typically going to be used for transient, lighting up of disease of lesions, mediated primarily either by EPR or just some kind of blood flow effects. But there was no active targeting component. Whereas here with this molecule, this was developed in the laboratory of Phil Lau in Purdue University. What Phil had done is he attached the commonly used fluorophore-FITC to a folic acid molecule, and very simple conjugation that was used here. And the principle was these ovarian cancers have, they overexpress the folate receptors, so you can get binding, receptor-mediated internalization, and a nice localization or concentration here of this fluorescent signal. And the effect of that here was what the surgeons were able to see with the white light could then be augmented here by a fluorescence signal. And the really cool part here is when you can do these overlays, and in addition to seeing kind of the lesions that are more obvious to the unskilled eye, such as myself, but you can also find some of these very small lesions that might be tougher to see just with the eye alone. So this was really a huge step forward. And a short 10 years later, in 2001, shown here in November, we get the FDA news release that the compound OTL-38 known as Cytolux, now was received FDA approval for use of intraoperative imaging in patients with ovarian cancer. Now, the difference here is they did change that fluorophore from FITC, which is a visible dye, to a near-infrared dye. And quite a bit of work was done behind the scenes with this molecule, which ultimately led to its approval. But really, the important thing here was that this showed a pathway for developing receptor-targeted FGS agents and gave researchers such as myself a continued motivation that there is translational opportunities with this and to move technologies forward. So our area of interest is in neuroendocrine tumors. That's what my lab has been focusing on for the last decade plus. And the reason surgery is important in this disease is kind of unique because we think of surgery as being a primary treatment for localized disease, which is common in most solid cancers. But with NETs, even in a metastatic disease setting, those primary tumors are active. They're secreting a ton of hormones, and they create a lot of, they basically impair quality of life for patients, create a lot of, effects associated with carcinoid syndrome, vomiting, flushing, diarrhea. So debulking of that primary, even in the metastatic setting, or even removal of it is critical. But the difficulty here is that these lesions tend to be small. They're really multifocal in their presentation. So as surgeons will tell you, that intraoperative localization of these is not straightforward. And if there's any method to detect them better, it would be very valuable. As a result of this type of complication, what's happening is there's a very high incomplete resection rate of up to 45% in these cases. So clearly you can see that new tools for surgical oncology could have an impact on patients with neuroendocrine tumors. Where we are very fortunate by picking this disease is we did not have to do biomarker discovery. We did not have to find a ligand that really truly works. All of this has been worked out since basically, about 40 plus years of work in the field. And that really stems from the discovery of this molecule, the synthetic 8 amino acid peptide known as octreotide. It's a synthetic analog of somatostatin. This itself is an approved therapy that's given to patients to treat the carcinoid syndrome effects that you see here. Okay, there's some of the different effects for the patients. So this is not really meant to be a therapeutic type drug. It's more for palliative purposes. But as you can see here, from a chemistry standpoint, this actually looks like a great molecule for labeling. So a lot of smart people have been working on this for a long time. And one of the first advances that was made was by changing the phenylalanine at the 3' position to a tyrosine. And that serves actually two purposes, is by adding this tyrosine, the water solubility of the peptide is increased, but also it enables iodination. And in this case, iodine-123 was the first radionuclide that was attached to octreotide. And this was done back in 1987. And this was the first true radiopharmaceutical developed for targeting and imaging of neuroendocrine tumors. Now you can see a short time after, this is not the, this is a little bit messy chemistry, stability issues, not widespread potential, not widely available access of these type of isotopes. So there was a shift to make this more user-friendly. And what happened here is instead of using an iodinating approach is a chelator known as DTPA was attached to the N-terminus of the peptide. What that allowed for was instead of using this halogenation approach is the radiometal indium-111 could be directly chelated into this and developed in a kit formulation. And whenever you talk about radiopharmaceuticals, kits are great because they can be managed by radiopharmacies, they can be distributed widely, and that means more accessibility, broader use. So this was the state of the art. This gained FDA approval. And up until just a few years ago, this was the lone compound that actually was approved. Now, what happened is at the turn of the century, there was a big change that happened in the field. Kind of, I would call it a true game changer, is by switching this chelating agent from DTPA, which has a limited number of radiometals that can stably chelate. DOTA was introduced to the N-terminus, shown right here. And then this allowed the chelation of gallium-68. Indium-111 is a single photon emitter, which means it can be used for gamma imaging, whereas gallium-68 is a positron emitter, and this enabled PET imaging. And when it was coupled with the fact that it's generator produced, means you don't need a cyclotron facility, very, very nice and small footprint automated systems, this became the de facto gold standard in the field for an extensive period of time until its approval about, I would say, about 10, 15 years later in the field. But really, this molecule was what ended up changing the field. And where it actually had even bigger impact was it kind of set the stage. It laid the foundation for what was known then as what became known as the field of theranostics. And this is a an article that's been really good for those of us in the imaging field, especially in the theranostics fields, published in Nature Medicine last year, talking about the potential opportunities with neuroendocrine tumors and with prostate cancer and potentially other molecules as well. But really what this is the blend of precision, or the opportunity to have precision medicine through a molecular targeted imaging approach, and then a rapid switch over to targeted radionuclide therapy. Now, the core of these, I'm not going to be getting into these topics at all, but the core molecule right here, again, is this DOTA-TOC or DOTA-TATE, which is basically a sister molecule of this agent. These are the foundation, these are the cornerstones because they were proven to have clinical success over a couple of decades, and they target with very, very high accuracy, diagnostic accuracy, outstanding pharmacokinetics, and they're easy to produce. So this ended up, in our mind, this was a great model to be using for the development of a fluorescent analog. And that was in fact our exact goal. Is when we're going to target these lesions, there's a lot of different approaches we could take and others have taken in the field, but we decided if it ain't broke, don't fix it. So our strategy was to make a fluorescent analog of DOTA-TOC, and building on kind of the things that I talked about here, it's established use, it's a selection tool for patients that enter the clinic with SSTR2 positive disease. We also thought it would be kind of cool that if we use this as the parent molecule, we'd have a built-in benchmark that we could use to compare the performance of our agent to. And also from the lessons we learned there, we could guide our optimization. So sounds pretty straightforward. Take this molecule, make a small change, and put a fluorophore on there. Actually, what really ended up happening was quite a bit of trial and error on our part. It took the better part of about 3 years to get this thing, 3 or 4 years to get it sorted out from beginning to where we actually got to the desired compound. And the reason for that was the DOTA molecule that you see here. We wanted to keep this integrated into the DOTA-TOC footprint because we know this works. You know, the configuration of the molecule is outstanding for high affinity binding, so we didn't want to disrupt this. What we did in that case was we took this backbone of the DOTA and we made what we called an MMC, a multimodality chelator. If you look at it on the surface, it's still the same N4, it's still got the same number of carbons. It's essentially a mimic of DOTA, but instead of this carboxylate group here on this on the secondary amine, what we did on this amine is we added an arm here, kind of a spacer, a functional spacer that has an azide. And what the azide allowed for was a simple click chemistry conjugation of any type of fluorophore that we wanted to put on. And in this case, this is commercially available IR dye 800 that we purchased from Lycor. Now, the work that you see here is summed up into this kind of one slide, was really developed by my chemist, Sukin Ghosh, who has made a library of these. And he did the unthinkable when I kept asking him to modify these about 10, 12 years ago, and we had no evidence to go off of, no publications to go off of in a sense. So he did an amazing job of developing this molecule and then versions, derivatives of it that we've used for other purposes. So what I'll also do is I typically cringe if I see a slide that's packed with data when others present. Nevertheless, I'm doing that exact thing right here, but I want to make this really easy to digest. This is the work that we did with our Gen 1 agent, our SSTR2 Gen 1 agent, which is the MMC TOC compound labeled with IR dye 800, the Lycor dye. This work was led by the graduate student in my lab, Servando Hernandez Vargas. He's been an absolute leader in the entire project from its inception. And then we had a tremendous contribution from my colleague, Susie Casas, who was then at MSK and now is in Munich at TUM, to really help us merge the optical data with our experience in probe development and radiochemistry. So the take-home message from this slide is that microscopies, traditional microscopy, confocal microscopy, showed us that our compound could bind to tumors that had the tumor cells that had the SSTR2 highly expressed, as opposed to the wild-type cells that lacked the receptor. So we're able to show SSTR2 selectivity in cells. We then progressed to in vivo imaging studies here, where you can see, again, same thing. If the tumor has the receptor expressed, we get very nice signal and very low accumulation in these wild-type tumors. To confirm that this effect was also could be seen at the tissue level, we resected the tissues and performed Odyssey scans, and you can see here again very nice signal in SSTR2 expressing tumors, and then nothing in the wild-type or in the background tissues. So this was an exciting result that gave us some indication of in vivo efficacy of the compound. And then we wanted to see, well, this is great in mice. How does this work in humans? So we're able to get human tissues from our colleagues at Baylor College of Medicine, and we were doing some ex vivo staining, kind of learning how the procedure works and developing this methodology. And ultimately what we saw is that the near-infrared signal that we saw on the Odyssey here in patient 2, and you can see in patient 3, corresponded really nicely with the tumor region of the compound that was marked by the pathologist. So these were done blindly, and we were really excited to see this type of correlation, and then no signal in the normal human pancreas. So we're feeling really good about things here. So we wanted to take it one step further. And these are small animal imagers. We said, how would this look with the clinical imaging system? So we took our mice and then we imaged them under the Da Vinci surgical robot just for a feasibility study. And we noticed we were able to detect tumor signal with the robot with a reasonable amount of 5 nanomoles that was injected into the molecule. So all in all, we were kind of excited to show for the first time that we could take that peptide that was used for a radiopharmaceutical, convert it into a fluorescent analog and actually show that it's binding to the tissues in a very selective manner and doing what it's supposed to. But as you guys know, I want to go one step further here. So this was, I show here the data that was with the Da Vinci. This is for minimally invasive. We also then, we did a collaborative study with colleagues at Onloom, Adam Usselman and Christy Lin, where what we wanted to do was see how would this work in a case where we had to do open surgery. So we implanted tumors in mice. We injected them with the compound, the fluorescent compound, and in this case, it did have the radioactive label on there. And then we performed a surgical procedure, which you can see here using their custom-built NIR imager. And you don't have to be a board-certified mouse radiologist to identify these tumors here. Clearly, we can see the tumor lighting up in a very nice fluorescent signal. We put that there. We expected it to be there. So we felt really good from a proof of concept standpoint. And we're able to do dose optimization. And this, importantly, was all done at ambient light, in ambient light. So this we felt really excited about. What we really liked here was that we started to see some signal outside of that primary tumor area, and we weren't sure what that was. So we thought we'd resect that anyway and see, was that a false positive, or perhaps did we pick up something? Because to the naked eye, if you're experienced in doing these surgeries, it looked pretty much like adipose tissue. And these tumors are not typically going to be metastatic with the sub-Q implant. But what we found here is that in addition to this gross volume that we see here in these 2 different mice, we saw these residual diseases, here are the snapshots, and we took them and we analyzed them by pathology. So in this first kind, we called it microlesion number 1. If you look at it right here, we stained it and it proved, we did confirm that it was cancerous. It was stained by H&E, proving it to be cancer. And then really excitingly, we found that it's very, very high SSTR2 expression. So the uptake that we were seeing was not really any kind of non-specific, but it was SSTR2 mediated. And then the same thing here for microlesion number 2, there's SSTR2 expression. So this was a very encouraging finding because that was unexpected. And that's really the hope that we bring, the hope that we have about what the technology could bring into the OR. So again, very excited about this work, but chemists tend to always think that there's room for improvement, right? We can keep tinkering with things. So we said, let's optimize this and see what can come next. So what we wanted to do is figure out, what if we have tumors that are not super high overexpressors? How can we get high detection sensitivity? We're going to have to reduce off-target uptake or maybe enhance clearance. And ultimately, we thought it'd be great to be able to image at earlier time points because the images you saw require 24 hours post-injection. This might have more compatibility and flexibility with clinical workflows. So the question really became, what are we going to change? Do we tweak something on the targeting agent? Do we think about the linker or the dye? And very fortunately, I run into a very important colleague now, Martin Schneerman, whose lab at NIH develops custom near-infrared dyes. I ran into him at a WMIC meeting. He had developed this new dye called FNIR-Tag. And his hypothesis was that the charge balance of this compound compared to the net negative charge of IR dye 800 leads to a lot less nonspecific binding. And they had shown that really nicely with antibodies in their animal models. And this dye right here was developed by an outstanding postdoc in his lab, Mike Luciano. And Mike produced a bunch of this material, put DBCO on it, sent it over to us. And then we were able to produce now what we call the Gen 2 compound, which is MMC-TOC here with the FNIR-Tag. But construct-wise, you can see very similar to our first generation structure, but now you have this charge balanced dye, which in theory will have less interaction with normal tissues. So I'm just going to walk you through how we ended up testing this. We did, this is a lot here, but really I want to keep it simple. We did conventional confocal microscopy to kick things off, comparing IR dye 800 to the FNIR-Tag version, and we saw good congruence between the two. So we're happy because we don't want to make things worse in the process of trying to make things better. So we're happy to see that both target the compound nicely, both can be blocked. So it shows some equivalence with the Gen 2 compound compared to the first one. And then for those that work in the fluorescence field, we also can do flow-based uptake assays, and where we compare the FNIR-Tag shown in red to the IR800 shown in black. And really the main thing I want you to take away from right here is that uptake was somewhat lower for the FNIR-Tag compound, but what we found is in the case of blocking studies, a lot of that uptake was still present with the IR800, which indicates that this does have higher non-specific binding, and which may be contributing to this, overall total signal that we see. Now, the cool thing about that chelator and keeping it in, that linker is not just a standard linker. We sometimes refer to the MMC as a radioactive linker, and it goes back to allowing us to perform traditional radioligand studies, which are truly quantitative, and to be able to compare our findings to the parent molecule DOTA-TOC. So here, if you just look at DOTA-TOC in blue compared to FNIR-Tag in red, you see pretty nice correlation across different cell lines here, which start with the highest level of receptor expression, decreasing down here to the H69s. And then, of course, these are just the wild type that do not express the receptor. So what we found overall was that the compound, the FNIR-Tag compound, tended to perform more similarly to DOTA-TOC than the IR800 did. So next, we wanted to continue to test this, and we went on to the in vivo studies. And in these small animal imaging studies, first we tested our animal model that had the SSTR2 positive tumors. We imaged early at 1 hour and 3 hours. And I think you can clearly see here that the IR800, while there is bright signal in this tumor region, there's also quite a bit of background signal that's still persistent at 3 hours. Whereas with the FNIR-Tag, you get very rapid clearance, which essentially allows us to have tumor signal and then high renal clearance, which is observed here. And if you look at this SSTR2 negative model, it's really encouraging here to see that there's nothing retained in the animal essentially except the clearance organs, whereas here you still have a high background of the molecule. Okay, and then we performed ex vivo analysis here. We saw probe uptake in both of the for both agents in the SSTR2 positive lesions. But if you look over here from the SSTR2 negative, kind of all the way down to the spleen, the FNIR-Tag has much lower accumulation, again, signifying less non-specific association. And that's captured here by this waterfall plot, where it shows that the irradiance change, basically the fluorescence signal of the FNIR-Tag in relation to the IR800, goes down in all relevant tissues. Slight increase here in the tumor. I think that's not necessarily that important, and then much higher clearance through the kidneys. So this is exactly what we wanted to do. We wanted to reduce that background signal because this is how we felt we'd be able to generate higher contrast. And this is that fold change in contrast compared to it. And as you can see, our goal initially for translation is going to be in the pancreas, and we're able to increase pancreatic signal or tumor to normal pancreas ratio by up to 3-fold just by changing the dye to FNIR-Tag. Okay, and then my postdoc in my lab, Solmaz Ava-Amidi, brought in a really nice skill set for us, able to image these tissues. So we're able to look at differences in tumor tissue, and we saw the same thing that we saw in vivo. Here, it's nice to have validation at the microscopy level. We see that again, and the really important thing here is that with the IR800 analog, you see lots of non-specific uptake in these SSTR2 negative tumors. Whereas with the FNIR-Tag, this is clean. It's not sticking to anything. And if you look here at our target tissues of pancreas and small bowel, which will be kind of a secondary goal for us for NET surgery, very, very low signal in these. So the takeaway from all this was that FNIR-Tag, it does have a little bit lower tumor signal, what we saw in these type of studies when we visualize. But what's really important, it has a much lower signal in the normal tissue. So we thought, okay, this is the superior agent, but for those of you that have known me in the last, I would say 10, 12 years, you think of me as somebody who works in the optical imaging field. But for those that go back beyond that and knew me from the beginning, I'm a radiochemist by training. I work with radiopharmaceuticals and I do a lot of PET and SPEC imaging. That's how I came up and got all of my training. So for me, when I think of imaging, I want to get something out of that data set, out of all those animals. And the information we can typically collect from PET and SPEC are really in-depth understanding of biodistribution. We're able to figure out, do we have the binding to the target right here, on-target binding? And then what is the extent of that off-target? How much of that is distributing throughout the body? We also can learn quite a bit about pharmacokinetics through serial imaging, because we can learn how is this eliminated from the body over time. And ultimately, what these allow us to do is to figure out if we have a panel of compounds and we don't know which one's the best, this is how we can select the lead compound to move forward with. And you guys can appreciate this, whether you're looking at these fused 2D coronal slices of a PET and a CT, or whether you look at these, awesome MIPS, maximum intensity projections, which give the 3D view. These are powerful imaging techniques, which give you a lot of information. So this is what I was used to. And then I get in the optical imaging field and things just got a whole lot simpler because our in vivo images are quite limited. If the tumors are sub-Q, you can see something, it'll be there. And of course, we know we put the tumor there. So it's really kind of I would say like a not so rigorous feasibility study, because this is the only information you get. Then, of course, if you want to find out what's going on inside, you do the ex vivo analysis of the tissues. And whether it's with these commercial scanners or these awesome custom-built scanners that have much more clinically relevant performance, we still are limited by the fact that we can only image things that are essentially on the surface. And if we want to know what's going on inside, we have to do ex vivo analysis. So really, the ultimate thing here is with the optical imaging, we're not, as far as the field stands, it's very challenging to produce the same type of information with the imaging that you can get like on a MIP that you could generate from PET. And you could learn and say, hey, I like that I'm seeing my target, but I don't like all this background and I got to make some changes. And this is not related to this presentation. This is a different fluorescent compound we made, but this is something that gave us a lot of incentive to figure out, or understanding of where we need to modify the compound. So when I learned a few years back that Mo Farhood was in our building and him and Charlie were talking down in the small animal imaging facility at MD Anderson about this machine called the Zera, it can do this cool sectioning. I was like, okay, I want to know a little bit more and see what's going on. So what they taught me was a term called CFT, Cryo-Fluorescence Tomography. This is the first I'd heard of it, but I pieced it together and I saw, okay. So these are a slide here, courtesy of Image, showing that CFT is an imaging technique which ultimately allows you to take these, to perform serial sectioning of these animals, obtain these 2D fluorescence and white light images, and then you can reconstruct them and compile them to form really nice 3D images. So I was definitely intrigued by this because I thought it could add a lot of value to the work that we're doing. And I thought an image like this looks really cool compared to what we were generating. So we thought we'd give it a shot, and we were working with Charles Kinsley and then the group at Anderson Small Animal Imaging Facility. So our goal was to bridge our macro and microscopic findings with CFT, Cryo-Fluorescence Tomography. We also wanted to see what BioD would look like in an intact molecule. Ex vivo is cool. Ex vivo does not capture blood. We don't have that blood component. We don't have perfusion. So we're never going to be able to really wholly reconstruct a PET-like 3D rendering that actually has that anatomical context. And we thought we needed this to really, truly figure out what was the best agent. So here are just the steps for those of you that have done autoradiography before in the nuclear medicine or with radiochemistry. I did quite a bit of that. Here's a mouse injected with the compound, euthanized, and then embedded in an OCT block that's frozen. And then you mount this into the Zera, and then serial sections are performed. And then images are taken of those sections and then analyzed. And the way this all comes together, this is a CFT fly-through. This is one of the readouts that we have that we could show you. So this is going from the very top of the animal all the way through to the bottom. And on the left here, you have the IR800 first generation agent. And what you see with this is the yellow arrow designates the tumor that has SSTR2 where we see signal, but this is the wild type tumor. This is a tumor that is really a control, doesn't have the receptor, but you still see quite a bit of signal in addition to a strong overall background signal. But if you look here at the FNIR-Tag compound, you can see a very different biodistribution, nice uptake in SSTR2 tumors, very low signal here, and essentially a clean background with the exception of clearance organs, which you see through the kidneys and then some elimination that's happening through the gut. But all in all, I think this gave us a very nice indication of how the agent looks in a whole body format. And then we take that one step further here, and we got the really cool 3D reconstruction. So these are basically like our PET MIPS, and I love these images. And for me, this, images are worth 1,000 words, and I don't know if 3D images are worth 1,000 to the third or whatever the math might be. But I was really excited because, again, this really drives the point home of how much background signal we see due to the IR800 throughout the body, whereas the FNIR-Tag gives a very clean profile, nice tumor demarcation, and then just it designates, kidney high renal elimination. So with that, we felt very comfortable going forward with the FNIR-Tag and digging into studies that are really focused more towards translation of the compound. We did a dose optimization study at 2, 5, and 10 nanomoles, injected animals, resected organs, and analyzed them. And after all the work, we found that there was really no essential statistical difference between tumor to muscle ratios or tumor to pancreas in this case. So what we did is we just said, all right, we'll pick the one in the middle. And we ended up picking the 5 nanomole dose to move forward with. And then we were able to do, we're really excited about here is our first test in a PDX model of NETs. Anyone who's worked in the neuroendocrine tumor field knows that animal models, but saying suboptimal is putting it very kindly and nicely. They've been quite difficult to generate. And our colleague Po Ear from the University of Iowa has this really cool neuroendocrine carcinoma model that it's a bilateral implant of a mouse where you can have SSTR2 negative on one side, SSTR2 positive on the other. And by using this model, again, we're able to show very nice receptor-mediated uptake in the animal model, confirmed here by ex vivo analysis of the tissues. And then also here you can see by the staining, again, SSTR2 negative was very low. And then here we see nice signal from the Odyssey and the receptor positive tumors. So this was a really encouraging result because we took that step into a real physiologically and clinically relevant animal model. And then we thought, now building on that, let's get some human tissues and stain with this new compound. And in this case, we have, I'll show you here, we have a primary pancreatic neuroendocrine tumor. We have a metastatic lymph node and then a metastases that was taken from the liver. In all these cases, there is IHC staining confirmed SSTR2 positivity. And what we found is our staining pattern pretty closely resembles the tracer localization pattern pretty closely resembles where the SSTR2 is located by IHC, and you can see in the normal pancreas signal is low. So this was, again, another very encouraging result. And that took us kind of to our final step here that ties everything back together, where we loop back to the use of DOTA-TOC, and we think it's a very powerful tool. It is used in patient selection to determine patients that are going to be undergo radionuclide therapy with lutetium analogs or now with alpha analogs. So our hypothesis was we could use the same strategy. If patients come in and they are confirmed to be SSTR2 positive via a DOTA-TOC PET scan, then they would also be candidates. If they're candidates for surgery, they'd be candidates to receive SSTR2 targeted fluorescence-guided surgery. So that was our initial kind of perceived workflow. And then in collaboration with Jennifer Bailey and Greg Simonek from UT Health, they helped us to produce a really cool orthotopic implant of BON SSTR2 expressing cells here in the pancreas. And then what we did is we let the tumors grow and we performed a PET scan as a selection tool. And once we confirmed that the tumors did take up the radiopharmaceutical, then the mouse was a candidate for FGS with the FNIR-Tag compound. And after injection, here's an in vivo image just before the tumors were resected. Here's a resection of the resected tumor itself. And you can see within that tumor bed, very little other signal was there. I mean, it's a very clean background. Clearly, you can see here by the ex vivo also a very bright tumor signal. And then the normal pancreas has essentially nothing there. And then muscle background is clean as well. And what we did notice was that there was this single kind of fluorescent foci on the spleen, which was unexpected. So from previous experience, we thought, let's section that all and see what happens. So when we looked at the pathology as expected, we know this is a tumor because we put it there. Here's the IHC stain showing intense SSTR2, which correlates very nicely with the co-localization of the fluorescence signal. And you can see clean signal here near infrared in terms of pancreas and muscle. But again, what was a very unexpected finding was that this fluorescence uptake that we saw here, this fluorescence, corresponded really, really nicely to IHC confirmed SSTR2. So in multiple cases here, we've had unexpected metastases happen, fortuitous. Maybe our technique is not so great with our implants, but we'll take it. But nonetheless, it really showed that we're able to detect these lesions very specifically, and the size of this, essentially, again, it's micro lesion based. So we feel confident that this type of detection sensitivity could translate into the clinic and give potential meaningful contrast in the OR. So, with that, I'm going to go ahead and summarize and outline our translational path for this molecule. So I think we hopefully showed you convincingly that FNIR-Tag is the preferred near-infrared dye for the purposes of our molecule. And what we're focusing now is on, from the drug side, is to do the cGMP manufacturing. And we have pharm tox studies here to evaluate the safety profile of the compound. And there's always opportunities here in terms of drug device combinations of how this can be developed. So we're actively exploring these depending on the type of surgical indication. And then we're developing a clinical plan with colleagues at MD Anderson that we're going to evaluate the dose and time optimization first, and then eventually move forward toward intraoperative tumor detection. So with that, I would like to acknowledge an amazing group of people. This has been a huge undertaking over the last 9+ years in the lab from when we started at the absolute beginning. And I'm very thankful to have all the colleagues from my lab in UT Health and colleagues that you see listed here that have really helped us to move this forward. And I will also acknowledge our funding sources and thank you all so much for your attention.